Can we start now?
Yes.
Okay. Good evening, friends, and welcome to today's webinar. This webinar is on evaluation and management of chronic ulcer. This is a very common clinical condition we come across day-to-day practice. Varieties of ulcer we face in our clinical practice, starting from ischemic ulcer or venous ulcer or trophic ulcers. So today we'll discuss extensively about this, how to evaluate the ulcer and what are the different methods of management of chronic ulcer. Today's speaker is none other than Dr. Diwakar Mishra. He is an alumni of SVNIRTAR. He passed out from SVNIRTAR in 2020. He is a very good teacher. Whenever he takes seminar, he used to talk very interesting things. And he is also known in his area as a good surgeon with good skills for deformity correction. And we really appreciate the work of Dr. Diwakar is doing in his area regarding deformity surgery, including deformity correction and one other soft tissue procedures. So without much wasting of time, let us invite Dr. Diwakar Mishra to present his talk on evaluation and management of chronic ulcer. Diwakar, please.
Thank you, sir. Thank you for your kind words. Am I audible to all?
Yes,
Sir.
audible.
So, as we know that ulcer is a multidisciplinary problem, starting from general surgery to neurosurgery or endocrinology. Everywhere we will face the ulcer. And here in my place, I am getting calls from the general surgery and endocrine mostly for the ulcer management and expert opinion. So I will highlight main important points of ulcer evaluation, not very basic things. Suppose in MBBS, we were during the evaluation of ulcer, we were taking history very deeply. So everyone is knowing that part. My slide is being changed or not?
नहीं सर, इनिशियल स्क्रीन पे ही है, फर्स्ट स्क्रीन पे ही।
Okay. Now?
Yes, it's changing now.
So,
Please go
girls, sir, because of I think poor signal reception, I have to keep my camera off. Then only it will change.
Okay.
So, sir, during history taking, we should ask about the duration of ulcer, which may be which may vary according to the location. There is a lot of confusion in the defining whether it is acute or chronic, but actually different ulcer has its own definition for acute or chronic. Suppose in duodenal ulcer or aphthous ulcers, it is different. And when we talk about the leg ulcers or the pressure ulcers, then according to the NHS UK, an ulcer is called acute when the duration is less than 6 weeks, and chronic when its duration is more than 6 weeks. Then we have to ask about the mode of onset, whether it is secondary to trauma or it is developing spontaneously, because a lot of diseases we face in routine OPD, where there is development of the spontaneous development of the ulcer. Even if the ulcer is because of the trauma, then also we have to take the history of underlying other comorbidities and like the vascular diseases and diabetes mellitus. Okay. Then comes to the pain. as we know that acute inflammatory conditions are very painful. So when the pain is severe or the ulcer is very painful, then we have a clue of acute inflammatory condition. And if the pain is less or mild, it indicates the chronic inflammatory condition. And if it is painless, then this gives the clue of malignancy, because malignant ulcers are mostly painless. Then discharge, if whether it is discharging serous fluid or uh, any blood or purulent discharge, because healing ulcers are mostly have the very scanty serous discharge, and purulent discharge is mostly because of the pyogenic bacteria. And if it is bloody discharge, it may be because of the malignancy, because of the highly vascular structure. Malignant ulcers are bleeding on touch. Then we have to take the history of claudications to rule out any vascular disease. Other associated diseases, we have to take the history of diabetes mellitus, alcohol intake, vitamin D deficiency, peripheral arterial disease, and pernicious anemia. All these are causing the ulcer. Then coming to the examination part, in general examination, we have to take three important parameters: blood pressure, which is known for the martorial ulcers, which are seen in inner side, means medial aspect of the distal part of the lower limb, and pedal pulses, bilateral, tibialis posterior, and posterior tibial artery and dorsalis pedis. And we have to compare it from the upward impulses, and then we have to see whether there is any disparity in the volume of pulses or not, which can give you a very good clue about the peripheral arterial disease. And lymph node, any infective pathology, mostly the tubercular ulcers have the tubercular lymphadenitis also, which is associated with ulcer. Then the local examination and a spatial examination. I will not discuss here the systemic examination, that is very basic ambiguous level stuff. So coming to the local examination, the inspection site, if it is present in the bony, on the over the bony prominences, or on the heel, on the medial malleolus. In the bony prominences, mostly ulcers are the pressure injuries. On heel and the first head of first metatarsal, the diabetic foot ulcers, and then the medial malleolus are the varicose ulcer or the venous ulcer. The shape of ulcer give the clue about the etiology: oval, circular. Oval ulcers are mostly because of the syphilis. Syphilitic ulcers are oval in shape, circular or the tubercular, and the irregular ulcers are because of any malignancy or any laceration. Size give the clue of the healing time. Mostly the small ulcers take less time if it is not complicated, and if the size is very large, then it will take more time to heal. And coming to the surrounding skin, if surrounding skin is red edematous, it is a sign of inflammation. And if it is normal, then it may be because of the chronic inflammation or other pressure injury related ulcers. Number, if it is more than one number, it gives the clue about the tuberculosis and the vascular venous ulcer, that is because of the varicose vein. Edges of the edges of the ulcer, which may be sloping, punched out, or undermined. I will show in the next slide. Margin everted or rolled out, pale bluish. Everted margins and rolled out margins are seen in a different type of the malignancy. Pale margins are always indicative of the ischemic ulcers. Bluish margins are always indicative of the venous congestion, which is a good sign for healing. Discharge, mostly scanty serous discharge is in healing ulcers, purulent in the pyogenic bacteria infected ulcers, serous sanguineous ulcer in tuberculosis, and more bloody discharge comes from the malignant ulcers because these are highly vascular. So they bleed on even touching. These are the edges. This is edge and this is margin and this is floor. Means the area which is connecting the margin to floor is known as edge. Undermined edges may be seen in the tubercular ulcer or even in the pressure ulcers, we get the undermined edges. Punched out margin are mostly sign of the non-healing ulcers seen in the diabetic ulcer. Sloping edges, these may be healing ulcer or even in non-healing ulcer where we see the skin deprived and struggling thin papery skin. There also we get the sloping edges. Inverted margin is seen in the squamous cell carcinoma and rolled out is mostly seen in the basal cell carcinoma. Now, to confirm the finding of the inspection, there is palpation, palpate the tenderness, whether it is tender, mildly tender or non-tender. I have already told about the basic etiology. Edges and surrounding skin, and duration is present in chronic ulcer. I have seen in pressure ulcers because of the massive fibrosis under the surrounding skin. There may be enduration, and other differential of enduration is the malignancy. Base, similarly, the base of an ulcer may be non-endurated or endurated. Non-endurated is in acute ulcer, and chronic ulcer may get the endurated base. Depth may be deep or superficial. Different management based on the depth, I will discuss later. Bleeding, you have to check out the bleeding, whether it bleeds on touch or not. Fixity to surrounding skin. Fixity to surrounding skin is because of the adhesions, because of the malignant growth. Here also during the when we discuss about the palpation, here I will discuss about the National Pressure Advisory Panel classification of the pressure ulcer. My focus is only pressure ulcer and the diabetic foot ulcer in this presentation. So in stage 1, pressure ulcer, the skin will be intact and you will get only the non-blanchable erythema. Non-blanchable erythema means when you will press with it with thumb, this will not blanch, means this will not change its look from pinkish to pale color, but it is very difficult to see the blanchable erythema when a person is having the dark complexion. So in these those patients having the dark complexion, we have to check regular the temperature of the bony prominences by non-contact thermometer and compare the temperature of that bony prominence with the that pressure tolerant area, which is equally it means similar. Like if the bony prominence is exposed, then the pressure tolerant area must also exposed. If it is covered, then pressure tolerant area must be covered. If one is covered and one is uncovered, then make both uncovered and let the covered area to come at the same temperature with the uncovered area, then you will get the appropriate temperature measurement of the developing pressure ulcer. Then stage 2, here skin, the depth of pressure will be up to the dermis at the stage 2. In stage 3, dermis will be lost and the subcutaneous fat, that is the superficial fascia, will be exposed. And in stage 4, from muscle to bone, everything is exposed. Similarly, this is Wegener's classification for diabetic foot. Here, grading is from 0 to grade 5. 0 is no ulceration is there, but the foot is at high risk according to the monofilament testing. I will discuss that in a later slide. Here in grade 1, only skin is lost and underlying tissue is intact. In grade 2, there is loss of skin and underlying tissue. Okay, means suppose the ligament and the muscles, but the difference between the grade 2 and grade 3 is only the formation of abscess. Okay, bone is not involved and there is no formation of abscess. Here in grade 3, the ulcer is more deep. There will be a diffuse cellulitis or abscess formation. Often it is associated with the osteomyelitis. I think we are getting mostly diabetic foot in this stage. And these two are by the management and also by the underlying etiology, these two are different. Grade 4 is localized gangrene, means there is compromise in the vascularity. Okay, and here there is extensive gangrene involving whole foot. So if you will go 2 or 3 times, we'll see these slides, you can mug up with it. These are some ulcers from NIRTAR and Mother Teresa Leprosy Rehabilitation Center with Abhishek San ulcer. This is the pressure ulcer. This is old diabetic foot having the squamous cell carcinoma. Patient was put for the amputation, and similarly here also. These are the sign of the non-healing. You are getting the pale margins. This is monofilament testing for diabetic foot ulcer. You have to check these 10 points starting from 1, 2, 3 and 8, 9, 10. And out of these 10 points, you have to check whether in minimum 8 points there is sensation or not. The size of monofilament is 10 gram. When you put the pressure, it must buckle up to 1 centimeter and contact time must not be more than 2 seconds. Means putting the monofilament over the foot and lifting it off, it must take max to max 2 seconds. Okay. So when there is loss of sensation is more 8 or more than 8 area, then it is said to be at high risk foot for developing ulcer. This is a flow diagram from the Bradham itself to decide whether the pressure injury or whether it is ischemic ulcer based on the ABI. You can also go through the Bradham to check it. It is very exhaustive. So I am skipping this out. Then coming to the investigation, basic investigation are the CBC to rule out the infection, and the ESR, which gives the clue of the chronic inflammation. blood glucose, fasting and postprandial, culture and sensitivity, X-ray. In this X-ray, for example, I have taken it from internet. It is not from my clinic. You can see this is ischial ulcer having the gas in the tissue and irregular margin of the ischial tuberosity, which is the sign of uh, osteomyelitis. You can go for the vascular Doppler, and if you need more sensitivity, then go for the CT angiogram. This is this picture is from NIRTAR, having the artery cutoff sign here. Then to confirm the etiological agent, you can go for biopsy also. Now, after the investigation, you have confirmed the diagnosis. Now coming to the management, we have the conventional methods. First is the wound cleansing. For wound cleansing, we are using the normal saline or sterile water, and recommended pressure for water or normal saline jet is 4 to 15 pound per square inch. Because if the pressure is less than 4 pound per square inch, you will not get the appropriate cleaning. It will lead, it will lift the colonies in the wound. And if it is more than 15 pound, then it may damage the granulation tissue. And even you can add the surfactant or antimicrobial solution whenever you are using the normal saline or the sterile water for the wound cleansing. And also the soap, which is very easily available. And one thing I would like to discuss here also, whenever a wound is created, the first thing which happens is the contamination. Means bacteria come on the wound, then it replicates and forms the colony. And around the colony, it develops the biofilm. And after a certain concentration of bacteria achieved, then only the wound is become infected. So wound cleansing always remove the colonies of the bacteria from the wound. And similarly, the debridement also. What is the need of debridement? Debridement for the disruption of the biofilm and removal of the necrotic debris. As we know that the necrotic debris are avascular structure. So any bacteria which is adherent or colonized over the necrotic debris, it will not be removed unless we are not using any mechanical method. Because antibiotic which is going through the blood cannot reach up to this necrotic debris. And this debridement is further classified as according to the type or the modality used, like the autolytic, enzymatic, sharp debridement, larval, low frequency ultrasound, or mechanical. Autolytic debridement, it is simple, putting the occlusive dressing and some moisture inside the wound. Then the assure or the slough will be removed by getting softened. Okay. Then chemical or enzymatic, mostly collagenase based enzymes are used for the enzymatic debridement. Conservative sharp, this is bedside surgical debridement by using the local anesthetic. And if you are in need of extensive debridement, that is the OT procedure, that is known as the surgical debridement. Then coming to the biosurgical or the larval, there are certain flies, mostly one fly known as the green bottle fly commonly. Its larvae are used for the biosurgical or the larval debridement. They create the alkaline atmosphere that inhibits the bacterial growth, and also they clean up the debris also. Then then other important is the mechanical debridement. We put the dry gauze inside the wound, and the debris are stick to the dry gauze, and we pull it out, and debris and other avitalized tissue will come out with the that dry gauze. But it is always the source of cross infection, dry gauze. Now coming to the wound care products, first is the gauze, which is most commonly used in India, I think. It is inexpensive, non-occlusive, highly permeable, highly absorbent. Dry gauze is used for the mechanical debridement. It can cause the airborne cross contamination. And if some fibers are left inside the wound, that can cause the granuloma. And since it is non-occlusive, it produces the local cooling, which may produce the vasoconstriction and hypoxia in the wound area, and impaired leukocyte activity, and ultimately delayed wound healing. Impregnated gauze, this is simple gauze which is impregnated with the petroleum, iodine, bismuth, silver, zinc, and it is commonly used for the skin grafting and burn where you need non-adhesive dressing. Impregnated gauze don't have the absorptive capacity, so it is not ideal for the exudative wounds where the heavy exudates are coming. Then the semi-occlusive dressing, it is nothing but G-dress. It reduces the moisture loss, means comparatively better. Theoretically, it is comparatively better than the gauze and prevents the cooling. It is not cost effective in comparison to the gauze because it definitely reduces the number of frequency of the dressing change, but still its cost is comparatively very high when we compare it with the gauze. Then coming to the transparent films, it is thin flexible form of the PU polyurethane sheet with one adhesive backing. So we have to peel off one surface and just stick it on the ulcer. It is permeable to vapors, oxygen, carbon dioxide, but not for the bacteria. It provides a moist environment, so it is used for the autolytic debridement. No absorptive capacity, and so it is not good for the infected and exudative wounds. Foam dressing, I'm leaving it because it is covered in the negative pressure wound therapy. Hydrogels. Hydrogels are certain polysaccharides and the protein mostly obtained from the sea beads. These are hydrophilic amorphous gel or in form of sheets. These adds the moisture to the dry wound. So these are used for autolytic debridement and for promotion of the granulation, as we know that the granulation is better form in the moist environment. But the drawback of hydrogel is this causes the maceration, and to prevent the maceration, we can use the barrier cream in the peri-wound area. And this needs the secondary dressing, means first you will apply the hydrogel, then above the hydrogel, you can use any adhesive, other adhesive transparent sheet or simple roller bandage. Then hydrocolloid, it's similar to the hydrogel, but the material is different. It is carboxymethyl cellulose or the pectin or the gelatin. Its absorptive capacity is more than the gauze. So this is used for the absorption of the exudates, it absorbs and swells and form a gel-like material. So this is for adding the moisture to the wound, and this is for the absorption of the exudate. There is a very long list of the wound care products: alginate, hydrofiber dressing, and hydroconductive dressing. Alginate and hydrofibers, all these are the naturally occurring substances obtained from mostly seaweeds. Hydroconductive dressing, the basic principle of this hydroconductive word itself explains the hydra means water, and conductive. So removal of exudate based on the principle of capillary. So there are fine capillaries which moves the fluid from the wound base to the center of the dressing by the capillary phenomena. Then silver dressing, there are several evidences that silver act as a broad spectrum antimicrobial, and so it is used from a long time for the dressing material. Honey, it is also observed in one study that honey reduces the duration of wound, especially the manuka honey. Manuka is an Australian plant, and it's honey extracted from its flowers. Understood, means its flower nectar is sucked by the bees and then prepared honey. That honey is most efficient in the wound dressing. Charcoal, it is again the adsorbent and so used for the exudative wound. Iodine, discovered in 1811, and since 1811 it was, am I audible, sir? Hello.
Yes, sir. Yes, sir.
Amit, is there any problem in
So screen flicker हो रहा है sir.
yes. Now?
No, it's
Still
okay.
sir flicker.
Okay.
No, it's
अब ठीक
okay.
है.
Okay, continue. Yes, sir. So iodine was used since 1811 to 1995. In 1995, the povidone was discovered, and the basic purpose of discovery of povidone was to reduce the concentration of iodine, because iodine was itself cytotoxic, and required amount for the antimicrobial activity was more. So after the development of the povidone, the use of iodine decreased, and povidone become a preferred agent over the iodine. Other modalities are the hyperbaric oxygen therapy. There is hyperbaric means we deliver the oxygen at the 2 times or 2.5 times the atmospheric pressure. Non-contact low frequency ultrasound, electrical stimulation, low frequency laser, stem cell therapy, skin grafting and flaps, and negative pressure wound therapy. Each and every topic here mentioned need one presentation actually. So I will not discuss all these things. I am confined to negative pressure wound therapy because it is a very large topic, and I hope I will be able to complete this topic in this presentation. So negative pressure wound therapy is nothing but it is subatmospheric pressure delivery to a wound bed by a suction device. It is this simple. This is a very generic technology which was not recent. The most recent form which we are using today is since 1990s, but its roots are going very earliest civilization. In the Roman era, there was general consideration that in population, there were some people, maybe male or female, they were thought that they had the hereditary power of the healing wound by sucking through their mouth. So there was in Roman era, in Roman army, there were some appointed people for these person, and they were known as the suckling healers. And then came the cupping glasses, small glasses. I will show in the next slide. This is historical photograph. Here a woman is sucking the wound of a person. These are small cups, and how these cups were used. They used a small amount of fire, say for a few moments. Then when the air become heat, it expands and expel out from the cup, and then they put this cup over the wound. And when oxygen, because of the oxygen deficiency, the fire become off and temperature become down, there is creation of negative pressure. So this is not a new technique. This is very generic technique and non-invasive also, which can be given in the continuous or phasic manner. This is the photograph showing basic principle. Here is the ulcer, and this is dressing, this is sealing film, and this tube connected to the vacuum device. Now coming to the mechanism of action of negative pressure wound therapy. So first, most important thing which negative pressure wound therapy do is the reduction of edema. How edema hampers the wound healing. So we, if we remember Guyton's this diagram, edema increases the fluid here, means extracellular fluid. This increases the interstitial fluid pressure, and same time, because of the high fluid amount, the colloid osmotic pressure decreases because the concentration of colloid also decreases. So this pressure decreases and this pressure increases, and capillary pressure is towards outside, and the plasma colloid osmotic pressure is inside the blood is remain constant. So overall net effect of this is capillary leak pressure is decreased. Means whatever things, whatever medicine or amino acids or other required things which have to come here for the wound healing are not coming. Second thing, what edema is doing, this is normal side, this is edematous side. If we see carefully, this is the capillary and this is the tissue cells. So these cells and capillary has very less gap, means whatever is being transported to the cell has to travel very less distance. But when there is edema, here capillary and the cell has large distance, and this is known as the diffusion distance. So whatever is coming to this tissue is have to travel a lot of distance to come to this tissue, and most remote cells will get the least amount of drugs, amino acids, and other required things for the growth and regeneration. These two are the most detrimental effects of the edema. So by negative pressure wound therapy, by we reduce the edema, and by reduction of the edema decreases interstitial pressure, improves the exchange of the oxygen, nutrients, and the metabolites. It improves the microcirculation and the lymphatic drainage. Second thing which negative pressure wound therapy provide is the moist environment. Because the dressing is semi-occlusive, this dressing provide the moist wound environment. Moist environment favors the reepithelialization, growth factors, action, angiogenesis, and the granulation, reduction of the irritation of the free nerve endings and the pain. Then negative pressure wound therapy gives the positive wound environment. What is the positive wound environment? When there is cytokines and growth factors and proteases in an equilibrium, it is said to be the positive wound environment. If these proteases will increase, these will start destroying the tissue. So what happens in exudate, there is high quantity of matrix metalloproteinases, and these are the reason for the destruction of tissue. Although these metalloproteinases are in less concentration, these are required for the wound healing. But when there is high concentration of the matrix metalloproteinases, they degrades the non-substrate proteins at the wound bed. So degradation of the non-substrate, say extracellular matrix, causes the poor signaling for the cell migration and their attachment, and ultimately there is delayed healing. So this exudate, which has the high quantity of the metalloproteinases, when this exudate is removed, the problem is solved. Then coming to the blood flow, it is study based. There are two studies with a good impact factor and the level of evidence which I included. One study with the laser Doppler has shown that there is 4 times increase in the blood flow at the 125 mmHg with pause of 2 minutes between each 5 minutes. Second study with the Doppler using the 50 to 200 mmHg in ischemic ulcer had shown the different distribution of the blood. In this picture, you can see that the margin or the area of skin which is close vicinity to the margin of ulcer was less vascular in comparison to the area which is far from the ulcer margin. So they decided to declare the safe pressure for the ischemic ulcer. They proposed that 70 mmHg for the soft tissue and 100 mmHg for the muscles is safe pressure for negative pressure wound therapy. Angiogenesis and the granulation. Negative pressure wound therapy promotes the granulation, angiogenesis, endothelial proliferation, and endothelial membrane integrity. In 2 studies, there was a histochemical analysis, and they found that higher level of interleukin 8 and vascular epithelial growth factor were isolated from those wounds which were treated with the negative pressure wound therapy. Another histopathological examination showed that expression of CD31, von Willebrand factor, beta fibroblast growth factors in the negative pressure wound therapy treated wound. And then mechanical stretching. This was an experimental study which found that fibroblast culture exposed to the mechanical stress by the intermittent negative pressure wound therapy has increased in P38 protein kinase, that is a marker for the cell proliferation. This is a simple dressing material. We have the foam to fill the wound, and below the foam, means between the wound bed and foam, there is another optional layer known as wound contact layer. It is not required in all the wounds, but where you need a non-adhesive dressing, or you need to prevent the granulation to come to the form. In those places, this layer is used. This is optional. This is a sealing film, and this is connection to the negative pressure machine. Wound filler material, commonly used the gauze, which may be antimicrobial impregnated or polyurethane form, black, this is black form, or polyvinyl alcohol form, that is white form. And what are the difference between the properties of these two forms? PU form has the large pores, so it provides the better pressure transmission from the upper surface to the wound bed, and more granulation. Since it is having large pores, so the growth of granulation tissue in those large pores is more. And polyvinyl alcohol form has the small pores. It provides a poor granulation. It is for deep wounds or undermined flap, sinuses, or exposed wounds. Wound contact layer, non-adhesive. This may be made from the petroleum, paraffin, or the Vaseline embedded. This is interface between the dressing and the wound or a graft. This minimizes the ingrowth into the wound filler, and so it minimizes the pain during the removal of form. Recommendation of the wound filler, wound contact layer. When we are using the form negative pressure wound therapy for STSG or full thickness skin grafting to bolster the graft, it has the evidence, level 1 evidence. Preferred wound contact layer is those which allow the fluid transit, and Vaseline is very poor in the fluid transit. It is shown by the various experiments, and its level of evidence is 3. Paraffin is not disturbing the pressure transmission, so it is thought to be ideal, level 3 evidence. Less adherent filler, gauze, level 3, or polyvinyl alcohol form. When these two things are used, then we can avoid the wound contact layer, because we know that the gauze is less adherent, and polyvinyl alcohol form is also less adherent because of the small pores. And another recommendation, where the rapid granulation is expected and high wound contraction is required, it has the level 4 evidence. And if anyone need, I can give all these studies. I have the PDF downloaded. I will share it in the group. Now, coming on the range of the pressure. Range of the pressure and effect of range of pressure on various parameters. The applied pressure was from 0 to more than 200 mmHg. Here we can see that the wound contraction is from the optimal wound contraction is from the -50 to -150 mmHg in these 1, 2, 3, 4 studies. And there is a detrimental effect, means there is no wound contraction, we can say, or very less wound contraction below the -50 mmHg. And similarly, the blood flow, we can see here 1, 2, 3, 4, 5, 6, 7. These 7 studies has found that the effect of pressure on blood flow is optimal from -50 to -150 mmHg. Then micro deformation, also this is from 0 to 150. Fluid handling, it is -50 to 100.
almost, or 120 we can say. And when there is more pressure over, means beyond the 125, there is more fluid coming in form of exudate, and its handling is difficult. And granulation, formation of granulation is optimal at -50 to 125. And if we increase the pressure more than 200, then there is detrimental effect on the granulation tissue. And near about -25, there is very poor formation of the granulation tissue. There are three modes of delivery of the negative pressure: continuous, or intermittent, or the variable pressure. Here intermittent means there is constant pressure for a certain time period, then zero pressure, then again continuous pressure for certain period, and then zero. And this is variable. The pressure continuously varies with time. So taking these three parameters and gauze and form, we have included a few studies, although there was numerous parameters which were compared in this study, but I included only the important parameters. First one is the wound contraction. Wound contraction, if we see that here the gauze was used with continuous negative pressure wound therapy, here gauze was used intermittent, and here gauze was used with the variable pressure. So the wound contraction was maximum wound contraction was noticed here, gauze with intermittent pressure. Similarly, wound surface and form form with negative continuous negative pressure wound therapy, form with intermittent, form with variable pressure. So the amount of granulation formation was maximum with form at with variable pressure negative negative pressure wound therapy with variable pressure, and with gauze it was with the intermittent. This is the histopathology of the base of bed of ulcer, and gauze and form which is used with the dressing. They take out the ulcer bed, and gauze simultaneously sliced it and examined under microscope, and they found that this one form gave rise the maximum amount of this is the maximum amount of growth of granulation tissue, which was with continuous negative pressure wound therapy and use of form. With intermittent pressure, form gave rise this much, and in variable pressure, this much granulation tissue was formed with form. And there is very poor or no formation of granulation tissue with gauze by application of any mode, continuous or intermittent or variable. Now coming to the various evidences. Negative pressure wound therapy after the partial diabetic foot amputation. This was a multi-center randomized control trial published in the Lancet in 2005. And a conclusion was, our results indicate that negative pressure wound therapy as delivered through the VAC therapy system seems to be a safe and effective treatment for complex diabetic foot wound. Treatment with the negative pressure wound therapy resulted in higher proportion of wounds that healed, faster healing rates, and potentially fewer re-amputation than with standard treatment. This is also from the Lancet, negative pressure wound therapy in the diabetic foot. The rate of wound closure was significantly better in negative pressure wound therapy group, but only when surgical wound closure were included in the analysis. Then comes the negative pressure wound therapy versus the conventional therapy on split thickness skin grafting. A systematic review and the meta-analysis. The conclusion was compared with conventional therapy, negative pressure wound therapy significantly increases the rate of graft take and reduces the rate of reoperation when applied to cover the wound bed with split thickness skin graft. No significant impact on the wound infection was found in this study. This was published in International Journal of Surgery in 2018. Another important paper from the Wiley Online Library, a solution for complex wounds, the evidence for the negative pressure wound therapy with installation. This is a different technique, means the negative pressure wound therapy with installation and dwelling time. Means they use the duck-in solution, put the duck-in solution with the dressing for 10 minute and followed by 1 hour negative pressure wound therapy. Again, they repeated for the complex wounds. And I did not included the result of this study because this was funded by Smith and Nephew. And I think there may be any biasing because of the funding. That's why I did not included the result, but it is a new phenomenon, means a new technique, installation and dwell time. We can also use in our setup with various antimicrobial solutions. Then negative pressure wound therapy versus the standard treatment in a patient with the acute conflict related extremity wounds. The conclusion of this study, this is also from the Lancet. There was a trend for a lower surgical site infection rate in the negative pressure wound therapy group compared with the standard dressing group. Although the statistical significance was not achieved owing to a lower than expected surgical site infection rate and lower than expected treatment effect. There was a significantly shorter mean duration of a hospital stay in the negative pressure wound therapy group, which may provide the significant cost savings. The surgical site infection rate in growing wound after the lower limb revascularization remain high despite being a clean procedure and remain a significant source of readmission and reoperation. Negative and other study, negative pressure wound therapy for treating the pressure ulcer. That is our interest. It is saying that the review contains the 4 study with a total of number of 149 participants. 2 studies compared the negative pressure wound therapy with dressing. 1 study compared the negative pressure wound therapy with a series of gel treatment, and 1 study compared the negative pressure wound therapy with moist wound healing. 1 study had a 24 weeks follow-up period and 2 had the 6 weeks follow-up period, which is very less actually. The follow-up time was unclear for 1 study. 3 of the 4 included studies were deemed to be at a high risk of bias from 1 or more risk of bias domains, and all evidences was deemed to be very low quality. Only 1 study reported usable primary outcome data, complete wound healing. but this had only 12 participants, and there were very few evident. There was little other useful data available from the included studies on the positive outcomes such as wound healing or negative outcomes such as adverse. So what I want to say that for pressure ulcer, the negative pressure wound therapy don't have any good quality data till now. So anyone can start. And this is my little effort in development of the negative pressure wound therapy machine. Actually, in early of my residency, when we were using the 1,25,000 rupees machine, and rent for that machine was 5,000 to 8,000 per week. Then me and Dr. Abhishek Sanyal sir both decided to develop, and we developed and tried many models. Ultimately, we achieved this one. We can adjust the pressure from this valve. This is the pressure gauge. This is the container. Its size is still to be bigger, means I have to install a bigger size container. And from here, we can adjust the time on time and off time for the intermittent negative pressure wound therapy negative pressure delivery, intermittent negative pressure delivery, independently from 1 minute to 10 minute on time and 1 minute to 10 minute off time. And I have a video. If it runs, I can show you. Hello, sir. Hello.
Yes, yes, yes.
Sir, is it all?
Handy machine. You can regulate the pressure from this wall
My video is not running.
according to your need. This end to be connected at the ulcer site. All it is, this suction cup is very small.
Sir, video is not playing.
Its size almost 500 ml. And from here, you can adjust the time, on time and off time, independently and separately. 1 minute to 10 minute, 1 minute to
And this another small video showing the functioning means how it on and how it off.
Your videos are not working well.
Sir, video is not coming.
No, it's not coming.
Okay. Then there is no meaning of running it, sir.
Okay, is this the last slide?
No, sir. One recommendation.
Yes, yes, please.
Sir, I would like to say that suppose like me, if you are getting the calls from general surgery or other specialties for the expert opinion on wound, then I will recommend this book from Springer. I have downloaded it, and I will share it in the group. If anyone want to increase his caliber and knowledge, and more deep knowledge is needed for the chronic wound management, it is very nice book actually, and it has those techniques are mentioned which I have never listened about those techniques in this. Thank you, sir. Thank you very much, sir.
Thank you, Diwakar, for your nice presentation regarding evaluation of chronic ulcer and management. So I would like to add something here that this regarding different forms of chronic ulcer management. One point we must not forget that regarding prevention of ulcer. That is most important thing. You have to give emphasis on certain things, how to prevent ulcer. If you have words like spinal cord injury ward in your department, so you might be getting number of cases with the varieties of ulcer. And the condition is very distressing when you have done a flap surgery and the patient is coming back with a huge ulcer and you don't have any tissue to cover it. And second point is that if the patient is coming with a multiple ulcer, those patients are because of huge protein loss from the site of multiple ulcer. So this is a challenge now, that how to heal the wound. The patient condition is so poor that neither we can go for surgery. Hello?
Sir,
Hello,
Diwakar
hello?
sir got disconnected, sir. So can you
Okay.
repeat the question?
Am I audible now?
Yes, you're audible.
Oh,
I
sir,
am audible or
actually,
not?
yes, sir. Now I switched to mobile. Actually, that laptop is not that is not working in laptop. Am I audible now,
Okay.
sir?
Yes, you're audible. So
Yes.
what I'm talking was that this negative suction wound therapy is
Yes,
a important aspect of managing. It's a helping tool during a distress condition. You have done a flap surgery, it is necrosed. There's no way, there's no tissue to cover, a huge area of open. If you won't cover it, there will be loss of increased loss of protein, albumin, and the wound is never going to heal. That becomes a vicious process. The protein loss, the ulcer will not heal. If the ulcer will not heal, then more protein loss. Patient will go to hypoxemia. Like that, the vicious cycle will continue, and you will be in problem. So, patient with failed flap surgery, patient with multiple ulcer, patient with severe malnutrition. These are the conditions where really this negative wound therapy really has a great role for managing it. Of course, the cost is a matter that even in our institution also we don't have that machine. Still, we are trying to have one machine. But if something indigenously prepared for managing the wound, then that is good also. Diwakar has developed a machine, and if it is really working, it's nice. And one more thing I got to know here is that application of this negative wound therapy over skin graft. I was not aware about that even this suction therapy can be applied over a skin graft also.
yes.
Diwakar, can you highlight? We have put skin graft, whether it helps in healing the skin graft, it helps in rejection of the graft, prevention of rejection of the graft, or how it is helping over a skin graft.
Sir, I think it is only bolstering, means making it more close contact with the underlying bed.
Okay. Okay, right. Normally also we do a lot of meshing over the split thickness graft. So that are the points where the exudate will come out. Maybe or the negative wound therapy will help in sucking the
Yes.
exudates through that wound, and otherwise also the graft will stick to the bed, and that helps in wound healing. So that is also new thing I came to know here today. So thank you, Diwakar. I think there is no more question in the chat box. The question, yes, one question from Saurabh. If there is osteomyelitis, I mean grade 4 ulcer, can this negative wound therapy will help?
Sir, first we have to debride bone actually, because until unless there is not only the infection, but you have to remove the sequestrum also, because sequestrum is devitalized, and until unless this devitalized tissue will be not removed, it will not be be more effective, I think.
Is there any evidence related to stages of ulcer with negative wound therapy? Which stage it better works and which stage it is contraindicated? Is there any evidences on that?
Sir, itself not based on the stages, but there are clear, there is a list of clear indications of ulcers, where it includes the infected wounds or ischemic ulcers, and like this. Means there is no stage wise. Suppose a stage 2 ulcer is becoming infected, So we can use the negative pressure in wound therapy to clear out the infection. And if it is ischemic ulcer, so the purpose of giving the negative pressure wound therapy is to revascularize it or giving the moist atmosphere.
Okay, I can see in the list, Professor Naveen Kumar sir is also there in the, is there in the participant works. Sir, are you here? Are you listening to us? Hello? Okay. I think there is no more comment, questions in the chat box.
Yes, sir.
So that means in case of osteomyelitis, the wound has to be properly debrided for
Yes,
the
yes, sir.
necrotizing tissue has to be taken out.
Right. Not only wounds, sir, underlying bone, if it is having sequestrum.
Yes, yes, that has to be taken out.
Yes, sir. Then only we can use the negative pressure wound therapy.
Okay. And he's about acute osteomyelitis. No, acute osteomyelitis is something different. You will get chronic osteomyelitis always. He's asking in acute osteomyelitis. No,
Yes,
it is
because,
always a chronic osteomyelitis. In
yes,
open wound, it is always a chronic, never acute.
because
once sequestrum is
mostly,
formed, it is coming under chronic osteomyelitis.
Sir, another thing, what cases we are getting in PMR are almost chronic osteomyelitis cases, neglected cases.
What I feel is that all physiatrists must know about this wound management. This is a very important thing. Everybody will come across this, whether it is a pressure ulcer from diabetic ulcer, a neuropathic ulcer, or from ulcer from spinal cord injury patients. So these are very often will get cases like this, and you must aware about all varieties of way of management of pressure ulcer. And certainly this negative wound therapy is really has a great role. It needs more awareness among our physiatrists for managing this complicated type of ulcers. Thank you, Diwakar. Thank you for your presentation. And I would like
sir,
to, yes,
sir,
yes, please.
sir, can you explain about the density of the foam or a little bit of detail about the foam that we should be using in case of this back therapy?
Steffi, it is mentioned in one study that the pore density in the PU form must be 400 to 600 per cubic centimeter. That is recommended for the dressing material, form dressing. And
Is it available
4,
in the market? Is it available in the market
yes,
for dressing? Do you have aware about that?
Sir, actually, the PU form which is available in the market has the same density, but main problem is the sterilization. The sterilization of form is very different from the smooth surfaces. So actually, I'm working also in that part, because the not only the machine is costly, the dressing material, that kit is also costly. So once I will get the proper sterilization of that form, I will inform you. I am going it through the various antimicrobial agent. Then I will go for the culture of that form, and when at least 2 cultures will be negative at 15 or 16 days, then I will be assured that I can use this form only.
Sir, so currently what is the sterilization technique that we use for these foams?
Form, actually, ethylene oxide, high pressure ethylene oxide is used to sterile the form. We cannot autoclave it. We cannot use the what we call the formalin and other things, conventional things. So ethylene oxide, it is they pack it in packets, and they put all these packets in the high pressure ethylene oxide for the sterilization in company. But I have to search the alternative of the ethylene oxide.
Okay. I
Sir,
would like to
and the
mention
gauze piece that we, sir,
yes,
Hello?
Steffi, please.
sir, and the gauze piece also we can use as an alternative. So
Yeah,
is there
yeah,
any
yeah. Yes,
specification
yes,
for
yes,
that?
sure.
Or the
I have you have not gone through the slides. Gauze piece is readily used, but the problem with gauze is it does not provide the granulation proper.
sir, but if at all we are using, is there any
Yeah,
specification for the gauze or the regular one we
it is
can use?
not effective in the formation of the granulation. for granulation to grow, the porous material to be used. Okay, that's why the
Yes.
black form, that is the PU form, is used
Yes.
for the granulation. And I am currently trying to sterile this PU form only. Because machine is ready, now comes to the cheap sterile material. Once these both things I will get, I will come to NIRTAR.
Okay, thank you, sir.
So just I one point to announce here that there are two coming webinars. One is on 20th April. It is by Professor Naveen Kumar. He will speak on assessment of permanent physical impairment or disability evolution. That is 20th of April. And
Yes.
one interesting talk is on presentation on 4th of May. That is on a video demonstration on advanced pain management. This is on live demo of interventional pain procedure in spine. That will be by Dr. Premanand. He is one of the expert in pain procedure. He has his own clinic that is at Chennai. So
Yes.
he has given his kind consent to have a live demo on interventional pain procedures in the spine. That will be on 4th May. 20th April will be by disability evolution by Professor Naveen Kumar. So
Okay.
this is for your knowledge. We will have
Yes.
one by one to webinar.
Sir, Naveen sir wants to speak, I think.
Okay.
Yeah.
Hello,
Hello.
sir. Good evening, sir.
Am I audible? Good evening.
Sir, you are audible. Perfectly audible.
So that was a very lucid presentation by Dr. Diwakar. Congratulations for your presentation. I have one query. I have one query. Do you have any experience of laser therapy for this wound or ulcer healing? Hello.
Sir, actually, in NIRTAR, there were laser therapy available, but because of lack of good evidences, we were not concerning it.
Okay, fine. Yeah. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir. Thank you so much, sir.
Okay. So if there is no more questions, sir, with your due permission, Naveen sir, we are
Yeah.
winding up the session. Thank you everybody for attending the webinar. I hope the coming webinar will be much more interesting on disability evaluation and pain management video presentation. Till then, we'll stop here. Thank you. Thank you very much for joining with us.
Thank you.
Thank
Good
you.
night.
Good night.